One thing is cardiovascular fitness, which I think is extremely important. In Europace, there was a study presented called CardioFit from Adelaide, which showed that if you are obese and if you train and if you lose weight, then you are a much better chance of keeping sinus rhythm after atrial fibrillation therapy. And that's very good news because it's actually a huge effect. And we're going to hear a similar presentation during this meeting. So it's actually two studies that come to the same results, and that really corroborates that this is the new thing. Lifestyle modification is part of arrhythmia therapy, at least for atrial fibrillation. Well, it is a clear risk factor for almost everything. I mean, the funny thing is that for all cardiovascular disease and many cancer disease, the same risk factors apply. But what is good about these two studies that I mentioned is that even if you cannot lose that much weight, just adding regular physical exercise into your daily routine will help you to be free from atrial fibrillation. So I think that is good news because lots of people are struggling with losing weight. And if you cannot do that, perhaps you can exercise regularly. It's both dynamic and static exercise. That's both sort of weightlifting, but most cardiovascular aerobic exercise. I think it has to be in equal proportions, but it has to be 200 minutes per week. So it's quite tough, in fact. It's not walking around the block. It's really relatively tough, a couple of hours a week. But what you can do, if you cannot do that, you can stand instead of sitting. So just having a desk that you can elevate will do some of the work, because that's static exercise. You just keep your muscle firm, and that helps in some ways. I think overall, yes. The downside of it is how to revert the effects when you need to do surgery, for example. I mean, if you have a scheduled surgery, you can just leave it out for 1 or 2 days, depending on the extent of surgery, and be on the safe side. But if there is an acute situation, then you have to revert it somehow, and there are drugs being elaborated to counteract some of these, like dabigatran, for example. And then you can use plasma, and there are ways of overcoming it. So the benefits are huge because you prevent so many more strokes, because it's not like they're replacing those that were formerly on warfarin. It's that those that never were prescribed anything, atrial fibrillation patients who never were prescribed any anticoagulants now get more anticoagulants, preventing stroke to occur, because they all reduce stroke risk by 60 to 70%. Well, they are better, in fact, in reducing the risk of ischemic stroke. The dabigatran in the higher dose was superior to warfarin. The apixaban, edoxaban, rivaroxaban, they all have a lower risk of intracranial hemorrhage, which is a downside of warfarin, which is what everybody's afraid of. Equally efficient, but a low risk of intracranial hemorrhage. And for the dabigatran in the higher dose, it's actually superior in prevention of ischemic stroke. The thing that people are prescribed stroke preserving therapy is the big thing, because there's a lot of under-prescription in that area, and it has huge economic impact. Every stroke has. Well, I think we look at age slightly differently. I mean, my clinic is full of 80-year-olds, full of enterprises. They're doing lots of things, not just playing golf and tending to the flowers, but they're active professional-wise. So I think you have to think that the 80s perhaps are the new 60s. And then, of course, there are other people who had a rougher life, who are already at the age of 50. So it's the biological age, not the chronological. And that means that therapies, even invasive therapies, are being pushed at much higher age groups than before.